Welcome everybody, my name is Winston Liauw. I'm the Director of Cancer Services Stream in South East Sydney Local Health District, and I mainly practice at St George Hospital as a medical oncologist. What I'm going to do is talk about some of the current statistics for colon cancer, describe a bit about screening and some high-risk populations, and look at the current treatment approaches. And it's not so straightforward talking about the current treatment approaches. I had a registrar today talk about one aspect of all the things I'm going to talk about today, and that occupied a good half an hour, so in just one paper, so we'll get into it. So colon cancer is the fifth most common cancer in New South Wales and Australia in general. Of course, there are gender-specific tumours that relevant in that discussion. Overall, over the last 40 years, colon cancer incidence has increased slightly, but has plateaued in the last few years. I hope that sits okay across those screens. For those of you that are interested, all these stats can be readily found on the Cancer Institute New South Wales website. You can play around with all the graphs and so forth. Colon cancer incidence. Colon cancer, all cancers are the consequence of successful ageing, I'm afraid to say. And so we see high incidence in older populations. But we are seeing a burgeoning incidence in younger populations as well. So in terms of the demography, if we just look over onto this side, so southeast Sydney has a slightly lower incidence than the New South Wales average. And we see that there are some hotspots like Hunter, New England and so forth, and some that seem to have at this stage lower incidences. There are risk factors, so for some reason New Zealanders, and this may be Maori New Zealanders, have a higher risk of colon cancer, and we see that from Asian populations there is a lower risk, but this is probably going to shift up to the baseline as we get into second generation Asian populations. And we see internationally, the classic example is the Japanese population who get gastric cancer. When they moved to California, they started getting bowel cancer. And so diet and inheritance all play a part in all of that. At the time of diagnosis, we expect that about a third of patients will have localized disease. What localized is confined to the bowel. This is the way the cancer registry records the information rather than T&M stage. So 43% will have regional disease. That means lymph nodes being involved. And about 20% will have distant spread. 7 or so percent, we don't know their stage at diagnosis for a variety of reasons. Some people just get a biopsy and there's no further information. The good news story is though that mortality is improving. So even though incidence has risen a bit, our overall mortality rate has declined over the last 40 years, and likewise 50 years here. And likewise, we see this across all of the age groups. There is, however, regional variation in mortality. And just as we saw a high incidence in Hunter, New England, there is a higher chance of death from colon cancer in that region and in the mid-north coast. Southeastern is below the average incidence, as are most of the major metropolitan regions. 5-year survival is gradually increasing, and we see across here that if you take all comers across these time periods, and 5-year survival is difficult because you have to wait for 5 years to get the results, which is why we have this historical data. But it's creeping up to the 60, almost 70% 5-year survival for all comers with colon cancer. And obviously the earlier you catch your cancer, the better that survival is going to be. As an aside, this is data for southeastern Sydney, and it's a little bit complicated, this picture, but essentially the 5-year survival rate in southeast Sydney region is better than the state average for pretty much every tumour type that we look after. Oops. So, I'll just go back. Now, I mentioned that colon cancer in general is a disease of old people, older people, but we are seeing an increase around the world in Western populations of young people under 40-year-olds who have colon cancer, and it's become such a prominent issue that it's really become a focus for Bowel Cancer Australia in going out, trying to work out why, trying to work out how to look after these people because they have different needs. I had 2 32-year-olds die over the Christmas and New Year period from metastatic colon cancer, both of whom had terribly aggressive disease. So that brings us to the bowel cancer screening program. This kicked off a few years ago now and has been slowly rolling out and is really changing our practice. It targets the ages 50 to 74, and it's every second year. You need to provide 2 samples in close succession, and they plan to complete the rollout of the program nationally by 2020. Once somebody gets a positive test, they need to be linked into either a colorectal surgeon or a gastroenterologist to have a colonoscopy. And the Cancer Institute is undertaking a big program now to try and facilitate easier access to colonoscopy, because you know it can be challenging to call up, get an appointment. Often some places there might be a couple of months before you even get to see somebody. So we're trying to bypass that, and Professor Imani Zekri, the head of gastroenterology at St George, is setting up a program where hopefully we can have a direct access clinic. You don't need to see a doctor first, you can head straight towards the colonoscopy. In 2014, the AIHW found that the program invitees had a 15% lower risk of dying from colon cancer and were more likely to have less advanced bowel cancers when diagnosed. And this is certainly what I'm seeing anecdotally in my own clinical practice. It's much less common for me to need to give adjuvant chemotherapy to patients with stage 3 colon cancer because people are getting diagnosed when they have earlier cancers. Unfortunately, there are also a bunch of people who are getting diagnosed late. So the test has a high degree of accuracy, 83% sensitivity and 93% specificity. And importantly, it's affordable. We just couldn't do colonoscopies on every single person in the population every 2 years. In 2015, a health pack report found that the test is best used for population screening rather than targeted groups. 7% of invitees returned a positive test, and of these, 73% had a diagnostic assessment recorded by the end of 2015. Of assessments occurring in 2014, there were 181 confirmed cancers. There were 638 suspected cancers and 3,500 adenomas detected, and adenomas, polyps, will go on to become cancers in the future. I think the important thing here is to understand about participation rates, and we have a target participation rate in the population, and it's based on the number of people, the proportion that send in their fecal occult blood test once it's been received, and then the number who go on to have the confirmatory colonoscopy once they've got a positive test. So we're trying to close that loop at the moment and get people to do the test and then have the colonoscopy if it's positive. Of course, many people had, as Mark's described it, don't do it because of the yuck factor, and also there was a glitch early on in the program with the quality of the test and some false negative results. There are high-risk populations, so Lynch syndrome is the most common inherited syndrome, and you can go to the EviQ website, which will give you very detailed information about Lynch syndrome and how to screen for it, and when you should screen for it. For these patients, they are at much higher risk of the general population of getting colon cancer, and we, depending on the subtype of Lynch syndrome, and there are different subtypes, we recommend annual colonoscopy from the ages of 25 to 30 years. And also you should obviously be going and chasing up family members and having them screened as well. Inflammatory bowel disease does increase your risk of colon cancer. It's particularly likely with some subtypes, and especially if there's long-standing untreated or inadequately treated colitis. And it's recommended that patients should have second yearly colonoscopies at least if they've had an 8-year period of colitis. So let's say we've had our screening and the diagnosis has been made. Well, what's next? The modes of presentation we see are positive fecal occult blood tests. We see people having scans for all sorts of reasons, and lumps are seen, usually hepatic metastases, and then you go chasing for a primary tumour. We have screening of high-risk individuals, and it's also unfortunately quite common for people to present to the emergency for the first time with a bowel obstruction or with profound anemia, and they proceed to emergency surgery. And certainly many of the cases I see would fall into that category. At the initial diagnosis, there'll be a colonoscopy unless there's emergency surgery. Most people will end up getting a CT scan of their chest, abdomen and pelvis. CTs are very easy to do. And if they're suspicious for metastatic disease but not definite, they might get a PET scan. You do tumour markers, normally CEA or carcinoembryonic antigen. I also do CA19-9 in my practice, but just remember, if you haven't got a diagnosis of cancer already, do not do the tumour markers, because there are false positives out there. I have people who are just smokers and they've got an elevated CEA, so you don't diagnose cancer with a tumour marker. Most patients proceed straight to surgery. Partly this is because more often than not the initial assessment is with a surgeon. Laparoscopic resection is the standard these days. It's been shown to be oncologically equivalent, but you will convert to open for complicated cases. Rectal cancer patients, however, require additional staging, and this is to ascertain whether or not preoperative therapy is required, so neoadjuvant therapy, and this will involve potentially radiation or chemotherapy and radiation to try and reduce the chance of local relapse in the future. So we look for encroachment on the mesorectal fascia, which is what defines the ability to resect the tumour with a clear margin, and we also look for the possibility of positive nodes, but that's also very difficult to identify on imaging. Some patients with rectal cancer will need neoadjuvant therapy, but they will need to have a defunctioning stoma first because they might be obstructed. Patients with metastatic disease will still often get surgery for their primary, and this may be associated with improved survival or management of obstructive symptoms or bleeding. Some patients end up getting stents. I'm not a huge fan of stents. They seem to be the thing you do before you get an laparotomy. And so I encourage, if there's really either of these things to go for a resection. Around about this time, the multidisciplinary team will get involved, and this will involve colorectal surgeons, and often there's a hepatobiliary surgeon on the team as well, medical and radiation oncology, nursing care coordinators, there might be stoma care, palliative care, and around the country and the state we grapple with how to incorporate GPs into this process, and also the patients, particularly for some types of cancers. The care pathways can be complex, which is why we have a multidisciplinary approach, and especially for rectal cancer, and especially if it's metastatic at the start, it becomes very complicated. Patients are discussed at diagnosis, but we often bring them back for further discussion at key time points if there's changes. If there's a relapse, for example, we now might need a liver resection. So after the resection, stage 3 colon cancers, which are node positive, are all pretty much routinely recommended for adjuvant therapy. As people creep over their 80s, we start to think very carefully about the tolerability of those treatments. Recent evidence has suggested that the historical standard of 6 months of chemotherapy can be modified and reduced down to 3 months of treatment for subsets of patients. And this is really important because the 6 months of chemotherapy is almost always associated with neuropathy, whereas if we can reduce to 3 months, then we can start to avoid some of the more severe long-term side effects. That's spelt incorrectly. We also consider adjuvant therapy for high-risk stage 2 disease, and this includes patients who have at least 2 of these factors, so perineural or lymphovascular invasion, tumour budding, low number of lymph nodes retrieved, microsatellite stable disease. We ascertain this from the pathology reports, which are all pretty much these days synoptic reports, so they will list each of these things, whether they're present or not. After adjuvant therapy, we would regularly review our patients to look after survivorship-related issues, manage neuropathy, fatigue, etc., and also to check for relapse of their disease. And this generally involves regular CEA and CT scan. There's some controversy in this space, so certainly some surveillance has been shown to improve outcomes, but the frequency of surveillance and how often you do certain tests has become controversial. Less frequent tests seem to be equivalent to frequent tests. My approach has been historically 3 monthly review for the first year, then 6 monthly for a year, then annually out to 5 years, or for people with more than 4 lymph nodes to see them a bit more frequently in that first 2-year period. Do a CEA and CT, or CEA each visit, physical exam and CT scans out to 2 years, and colonoscopy within 1 year of the initial surgery, which is for the surgeons to check the anastomosis, but also to make sure they haven't missed a tumour previously, and then every 3 to 5 years unless polyps are detected. At this point we'll also consider some of these other issues, and I know some of the other presenters tonight will be discussing these. Increasing exercise, losing weight is important for potentially reducing relapse, but also managing fatigue. Diet comes into that strategy. Bowel care is really important, especially if people have stomas and you might need to be interacting with the colorectal surgeon's stoma nurses. Stopping smoking is really important, and this goes back to the time of even when they're having chemotherapy, if they're having it. So it's quite clear now that continuing to smoke results in worse cancer outcomes, almost regardless of what cancer type you have. You might want to think of genetic screening. Some screening tests are done as part of the original pathology, but you may need to seek advice from appropriate people about getting formal testing. And I think the other thing that's really important from my perspective is not to forget the other medical problems. It's easy for me to get distracted by the cancer, but these people have other things going on. And I certainly will be, I think your family doctor should be looking after your diabetes and all this sort of stuff. So, metastatic disease. So, in the last 20 years or longer, there's been a paradigm shift for metastatic disease. So it used to be uniformly a disaster, but it's now potentially a chronic disease. And I routinely will see people that I've looked after for a decade with metastatic disease. And so these days with conventional chemotherapy and biologic therapies, we quote standardly median survivals of 2 to 3 years and 5-year survivals of about 5% with pharmacotherapy alone. If you can resect the disease,